Today I will be talking about headache, okay, as an example of the medicine station. So as an example of medicine stations, I have told you in the previous lectures about how to take history in medicine stations, which is a station where the patient is coming to you with a presenting complaint of headache. So today we'll discuss the branch of headache. All right. Before we talk about the structure for headache, I just want to give you some key principles for headache. Number one, if you open the cubicle and the patient is in severe headache, the patient is having a severe headache. Doctor, I have severe headache. Number one principle, do not take long history. Do not take long history. So the history will be short. The history will be brief. Number two, if the headache is chronic, so if you open the cubicle and the patient is talking to you normally, doctor, I've been having headache for 3 months, 4 months, don't forget to start psychosocial early. You remember in the history taking about psychosocial, which means what do you do for living and how is this headache affecting your job? Who do you live with? How is this headache affecting your daily activity? So if the headache is acute, short history. If the headache is chronic, start with psychosocial. Okay. So now I'm gonna discuss headache. All right. So when you open the door and you ask the patient, how can I help you? After confirming the identity, I'm Dr. Fatih Al-Bab, one of the general doctors here. Can you please confirm your full name and date of birth? How can I help you today? So P1, presenting complaint, the patient will say to you, doctor, I have headache. Doctor, I have headache. Go back to the medicine structure so you will explore. But before you explore, tell the patient, are you comfortable talking to me? Are you comfortable talking to me, or would you like me to give you some painkiller? If the patient is comfortable, go ahead with the history. And always, I'm really sorry about that. Are you comfortable talking to me? Sympathy and empathy. Then tell the patient, ask the patient the open question, tell me more. Can you please tell me more about your headache? The patient will tell you some questions, whichever. Then what to do? You remember? Socrates. So Socrates for the headache. Socrates for the headache. I'm just recapping the structure. When you ask Socrates for the headache, anything else? Then the patient will give you another presenting complaint. Then tell me more again until the last presenting complaint. After that, what's going to happen? After that, main concern. After the main concern, when you ask the patient, what's your main worry, what's your main concern, then you need to go for differentials. So, differentials for headache. And when we talk about differentials for headache, if you remember, I said to you that if the headache is acute, I will go for the acute causes. If the headache is chronic, I will go for the chronic causes. But either way, what are the differentials for the headache? If this is the head, so I will have the head from outside to inside. So from outside, first thing is the skull. So I will ask about any history of trauma or any head injuries. Under the skull, meninges. So I will ask about meningitis. So head injury, number one. Number two, meningitis. What are the questions for meningitis? Fever, shy away from light, neck stiffness, rash. Under the meninges, the brain. So early morning headache and the early morning vomiting. So early morning headache and the early morning vomiting. After that, eye, nose. So eyes, I will ask you, do you have any problem with your vision? Or do you wear glasses? Or have you changed your glasses recently? Nose, sinusitis. So in the nose, I will ask if this pain is worsened when you lean forward. Okay? All right. Then I have GCA, giant cell arthritis, as you can see, or temporal arthritis, as you can see. pain on combing, pain on chewing, pain in the eye. So pain on combing your hair, pain on chewing, pain on the eye. And don't forget that with the eye, we said any problem in the vision or any glasses, if the patient is wearing glasses. And don't forget glaucoma, which is painful red eye. So these are the differentials for the headache. So any case of headache, differentials, the head from outside to inside, head injury. So I'll ask about any history of trauma, inside, meninges, fever, shy from light, rash, neck stiffness, get in the brain, early morning headache, early morning vomiting, eye, any problem with your vision, you wear glasses, any change in your spectacles, and glaucoma, which is painful red eye, any pain in the eye, redness in the eye, nose, sinusitis, pain on leaning forward, pain worse on leaning forward, and then GCA. Don't forget that we have subarachnoid hemorrhage, but you don't need to ask about it because subarachnoid hemorrhage is meningitis minus fever. What do you mean, Dr. Mo, meningitis minus fever? So the symptoms for meningitis without the fever and without the rash equals subarachnoid hemorrhage. So by asking about the symptoms for meningitis, you have covered already subarachnoid hemorrhage because subarachnoid hemorrhage, SAH, meningitis minus fever and rash. Meningitis symptoms without fever and without rash, subarachnoid hemorrhage. And now we will be left with 3 headaches: cluster headache, tension headache, migraine. So that's all plus cluster headache, tension headache, and migraine. Cluster headache, tension headache, migraine. Okay? Cluster headache, tension headache, migraine. We know that migraine, one-sided headache. Tension headache is headache to do with stress, band-like headache to do with stress, and cluster headache. Okay? So these are the differential for headache. But there is one important point here. Do I need to ask all these differentials in every case? No. Do I need to ask all these differentials in every case? No. Whenever you have headache, explore presenting complaint in details. If it is chronic headache, you will go for cluster, tension, migraine, vision problem. If it's acute headache, glaucoma, GCA, meningitis, subarachnoid hemorrhage. So be careful. So the headaches, from all these differentials, I will divide them into acute and chronic. So if the patient is coming to you with headache, so after exploring the headache, if you explore P1 in details, then it will give you an idea. Is it chronic or acute? If it's acute, you can think of head injury, you can think of meningitis, you can think of subarachnoid hemorrhage, you can think of GCA, giant cell arthritis, you can think of glaucoma. Okay? But if it's chronic, you can think of migraine, tension headache, cluster headache, vision problem, glasses. Okay? So don't ask all differentials, as I told you, maximum 4. Okay, after asking differentials, don't forget to go to flows, but flows here is not relevant as I have already asked the question for fever. And after that, P2, P3, maftosa. P2, P3, maftosa. If you go back to day 1, you will realize that P2 is past history of presenting complaint. Have you had this headache before? And past medical conditions. Very important medical condition is hypertension as a cause of headache, hypertension. P3 is DASA. So don't forget smoking and alcohol. Smoking and alcohol. Diet is not a problem. Exercise is not. So what's relevant to me here? Smoking and alcohol. Maftosa. Medication, allergy, family history, travel and occupation? No. However, if the headache is chronic, I have told you early on, if the headache is chronic, occupation and social can come early. So if a patient is coming with you with headache that is chronic, occupation and social will come early. So let's discuss stations, headache stations, one by one. Okay? And this will be my structure. Okay? What are the stations that we will discuss? We will discuss tension headache. We will discuss premenstrual syndrome, PMS. We will discuss sinusitis. We will discuss migraine. We will discuss giant cell arthritis. We'll discuss subarachnoid hemorrhage. We'll discuss meningitis and hangover. Okay? So the key points are, so you don't forget. The key points. If the headache is acute, first of all, whenever you have a patient with headache, always sympathy and empathy. I'm sorry about that. Are you comfortable talking to me or not? Sympathy and empathy. Whenever we have a patient who's coming with acute headache, don't take detailed history. Short history. Whenever we have a patient who's coming with chronic headache, always bring psychosocial early. Psychosocial early. Why? Because if the patient is having headache for a long time, for 3 months, for 2 months, I always want to say to him, how is it affecting your life? How is it affecting your daily activity? What do you do for a living? How is it affecting your job? Because it's a chronic, okay? And if the patient is in severe headache and he cannot move on, he cannot move further, can you offer him painkiller? Yes. So if the patient is having chronic headache and he's able to talk and he's fine, you don't need to offer painkiller. But if the patient is having severe headache from the start, you can offer him painkiller after asking about Socrates. After asking about Socrates. So you need first to ask about the pain. Why? Because if you give him painkiller, the painkiller will mask the pain. Alright? And we've given you the differentials, and I said to you that with the differentials, be careful that you don't need to ask all of them at the same time. Okay? Alright. So now let's take the headache stations one by one. The first station. You are an FY2 doctor in the GP clinic. Michelle, 45 years old, presented with headache. Talk to the patient, take history, assess her concerns, assess her condition, and discuss her management plan. So this case will be the tension headache case. The tension headache. I will follow the same structure, but now I will give you the positive symptoms, the triggers, the examination, and the management. So the first case is tension headache. The symptoms, the patient will give you symptoms, yes. He will give you headache, chronic, band-like, and he will tell you that my neck muscles are tightened. My neck muscles are tightened. He will also give you the sense of pressure behind my eyes. I have sense of pressure behind my eyes. Not severe. 4, 5 out of 10. Chronic. Okay? And he will say to you that it lasts for about 30 minutes. It lasts for about 30 minutes to several hours. Okay? So that's when you explore about the headache. Now, be careful, because the triggers will be when you take history. When you take history, everything will be negative apart from lifestyle. So the patient will have a stressful lifestyle, stressful job, and anxiety. Okay? The patient will tell you that he is having a stressful lifestyle. So it can be job, it can be that, for example, that the headache starts before I go home. For example, when he goes or when she goes home, she's having a bad relationship at home. So basically, in tension headache, there will be a risk factor, and the risk factor will be stress. Okay? So always bring psychosocial. Always bring psychosocial. Because it's so chronic, because it's long-term headache chronic, always bring the psychosocial early, and the patient may tell you, yes, it is affecting my daily activity. Alright? So management of tension headache simply is two things. Number one, painkiller. Number two, the risk factor. So tension headache, it is not life-threatening condition. It is a headache that usually relieved by two things: painkiller, lifestyle modification. No need for investigations, no need for anything. If the patient is asking you for a CT scan, doctor, I want CT scan. May I ask why you want CT scan? Doctor, because my friend had headache and it was brain tumor. Then you can ask as in your differential about brain tumor, early morning headache, early morning vomiting, and then the patient will have negative symptoms. Then you can say to him, well, usually we tend to do CT scan if the patient is having early morning headache, early morning vomiting, fever, rash, neck stiffness. However, you don't have them, you don't need CT scan. So here the management will be two things, painkiller as well as lifestyle modification. So painkiller, as simple as paracetamol, as simple as ibuprofen, as simple as that. Okay? So I will talk to the patient about the painkiller. So paracetamol is the one. Okay? If the patient is pregnant, paracetamol. All right? And then I will be talking about the risk factor, the trigger. So the trigger could be, as I mentioned to you, work. So you have to talk about work. You have to talk about his job. If it's his job, If it's stress at home, you have to give him technique on how to manage the stress. So lifestyle changes, for example, like yoga, massage, exercise, relaxation techniques. Okay, these are all relaxation techniques. Okay, so you can talk about preventing tension headache, simply by, if you want to keep a diary, to try to write down the times of the headache and what is triggering it. That's all of the things. Okay, you can talk about other regular exercise to prevent it, other relaxation techniques to prevent it. Okay, maintaining a good posture, and ensure that you are well rested, well rehydrated. All right. So NICE guidelines says that there is a course of up to 10 sessions of acupuncture over 5 to 8 weeks period can be beneficial, right? Safety netting, always safety netting any patient with headache, always safety net for meningitis. If you have any fever, if the headache is continuous, if it's not relieved, come back right away. That's tension headache. Okay, now I'm going to be discussing the second type of headache, which is premenstrual syndrome. You are an FY2 doctor in the GP clinic. Rachel, 31 years old, come with a complaint of headache. Talk to her, address her concern. Okay, again, I will follow the structure. Presenting complaint is headache, tell me more, Socrates, explore, anything else, concern, DDs. However, what are the positive here? The most common symptoms here for this lady will be mood swings. Her mood will be up and down. Okay, irritable, anxious, feeling upset most of the time, trouble sleeping, tired, and she can say to you, I have breast tenderness, okay, spotty skin, greasy hair, change in appetite and sex drive. These are all symptoms in addition to the headache. So be careful. So again, the patient who's having premenstrual syndrome, when she comes, she can present with headache, representing complaint headache. Explore it, ask about everything, and then when you ask about any other symptoms, yes, she will give you these symptoms: mood swings, feeling upset, anxious, irritable, tired all the time, trouble sleeping, breast tenderness, spotty skin, greasy hair, change in her appetite. Okay, and her sex drive. All right. So now, on examination, again, as we know, we'll verbalize everything. We'll verbalize the vitals. We'll verbalize the vitals, and we'll verbalize the neurological examination. Everything will be normal. And when you talk to her about premenstrual syndrome, which basically that is causing headache, provisional diagnosis, it's a condition that is because changes in the hormone levels during the menstrual cycle. So a condition that is caused by changes on the hormone levels that can cause such headache, and it's basically during the menstrual cycle. Okay, so management, how to manage this condition, how to manage it. We know the steps, we know the structure, but basically this case, the management is depending on lifestyle changes. So I have to tackle 4 things. So in the management, I have 4 points. 4 points in the management. Number 1, lifestyle changes. Number 2, medication and CBT. CBT is cognitive behavioral therapy. Number 3, things to avoid. Number 4, specialist. So when I talk to her about the management, so number 1, lifestyle modification. So I will basically talk to her about things that will be done in terms of lifestyle that will improve this. Number 1, like what? Regular exercise, healthy diet, okay, plenty of sleep, get enough rest, 7 to 8 hours. Try to reduce the stress if she gives you a stressful factor. Again, diary, she can write down about her pain and the timing. Okay, that's number 1. So lifestyle modification. Number 2, if you notice that lifestyle modifications like this. Number 2, medication and CBT. CBT is talking therapy. which is cognitive behavioral therapy. But it is talking therapy. So When I tell her about talking therapy, so I'll say to her, yes, there are sessions, talking therapy, where you will talk about your headache and will tell you about techniques on how to deal with it, talking therapy. Or medications, which is hormonal medicine. So hormonal medicine, like the COCP, sometimes they give COCP as management, or antidepressant sometimes. So that's a medication plus CBT. So number 1, lifestyle. Number 2, medication and CBT. Number three, things to avoid. Avoid smoking. Avoid too much alcohol. Number 3. So number 1 and 3, which is 1 lifestyle, 3 things to avoid, is basically basic. Diet, exercise, smoking, alcohol. So premenstrual headache is all about basic. Okay? So number 1, lifestyle, exercise, eating healthy, and this and that. Number 2 is medication and CBT. Number 3 is avoid smoking and alcohol. Number 4 is specialist. They can be referred to specialist if the symptoms persist, if it's not improving, if it's persist, if after all of this it's not working, gynecologist or psychiatrist. Okay? So follow up. Yes, follow up. You don't need to give timing, as we said before. So if you're gonna have a follow-up sessions, you don't need to give timing. Okay? All right. Then I will talk about the third station, which is sinusitis as a cause of headache. You are an F5 doctor in the GP clinic. Linda George, 33 years old, has come to you with a complaint of headache. Talk to her and this is your concern. Again, how can I help you? Headache. Sympathy and empathy, and always ask her, are you having the headache right now? Tell me more about the headache. Socrates. Anything else? She will give you any complaint. Again, explore more. Concern, DDs. One of the DDs, sinusitis, as you can see. Headache that's worse on leaning forward. Okay? So, what are the most common symptoms here? The most common symptoms here, what are? The most common symptoms. Number 1, she can give you a risk factor of flu, common cold prior to this headache. Number 2, she will tell you pain, swelling, tenderness around the cheeks and the eyes and the forehead. So, she having pain, tenderness, swelling around the cheeks, eyes, forehead. Number 3, blocked nose, congested nose. Number 4, reduced sense of smell. Number 5, green or yellow mucus from the nose, greenish or yellowish mucus from the nose. Number 6, toothache, pain in his tooth. Number 7, bad breath. Okay, so basically these are the most common symptoms, the most common finding that you will find in the history, apart from the headache. Okay, on examination, vitals will be normal, but when you palpate the sinuses, there will be tenderness. Okay, so how to manage, and how to give her provisional diagnosis. Sinusitis is swelling of the sinuses. Usually caused by infection. The trigger is infection. Don't forget also to ask about allergy as a risk factor. Okay, it is common. Usually clears up on its own within 2 to 3 weeks. Okay. However, medicine can help sometimes. Okay. So sinusitis, swelling in the sinuses, triggers caused by, it could be infection, flu-like symptoms, viral infection. It goes on its own within 2 to 3 weeks. All right. So management. Basically, I will give her general advice. So the management, number 1, general advice. Number 2, medication. Number 3, referral. So management, general advice, medication, referral. General advice, medication, referral. General advice, medication, referral, surgery. So 4 points. Again, general advice, medication, referral, surgery. So general advice, plenty of rest, plenty of fluids, avoid any triggers, avoid smoking. So that's general advice. So the management will be 4 parts. Number 1, general advice. Number 2, medication. Number 3, referral. Number 4, surgery. So general advice, plenty of fluids, plenty of rest, avoid smoking, and avoid any triggers that can cause allergy. Okay? Cleaning your nose with salty water, solution to ease the congestion. So this is number 1, general advice. So general advice, I say 4 things. Okay, what is the second step? Medication. Like what? Like painkiller, paracetamol, ibuprofen. Don't give aspirin to children under 16. Number 2 medication, decongestant, nasal spray or drops. Number 3 medication, salt water nasal spray. Number 4 and finally, they can give sometimes steroid spray or drops. So this is the second part, which is medication. So number 1, general advice. Number 2, medication. Number 3 in management, which is very important, is referral. When to refer to the ENT specialist, ear, nose and throat specialist. When would referral be indicated? If still have sinusitis after 3 months of treatment. If you treat her and still have sinusitis for 3 months, refer. If she keeps getting recurrent sinusitis, if she's having the symptoms only on one side, okay? So that's the third step, which is referral. When do I refer? Finally, surgery. By the way, when we talk about medicine, we have mentioned painkiller, we have mentioned decongestant, nasal spray, we have mentioned salty water or salt water nasal spray, we have mentioned the steroid. You can also give antihistamine, and sometimes antibiotic if there is an infection. Because sometimes it can get infected. And finally, as we spoke, surgery. So surgery, I'm not going to talk about it in details, but you can say if that all doesn't work, we can refer you for surgery. And by that I mean there's a surgery called FESS, which is functional endoscopic sinus surgery, but you don't need to talk about it. Okay, so in terms of management, general advice. Number 2, medication. And the medication I said, nasal spray, salt water spray, paracetamol, antihistamine, antibiotic, steroids. Number 3, referral. When to refer? If it's on one side, if it's not relieved, if it's recurrent, if it's more than 3 months, and then surgery. Okay, then I will come to the next station, which is migraine. You are an FY2 doctor in the GP surgery. Emily White, 30 years old, has come to you with a complaint of headaches. Talk to her, address her concerns. Okay, again, how can I help you? Doctor, I have headache. Sympathy, empathy. I'm really sorry about that. Do you feel the headache right now or not? Sympathy and empathy. Tell me more about the headache. Socrates, anything else? Okay. What is the complaint that she will give you? What is the positive finding here? The main symptoms, she will give you headache in one side. One-sided headache. Okay. Number 2, she will give you the pain. She will tell you it's moderate. Sometimes it's severe. Throbbing-like sensation. That gets worse when you move. When you start moving, and it prevents her from doing daily activities. Other symptoms, she can complain of sickness. She's feeling sick. Or she can complain of increased sensitivity to light and sound. All right, be careful, because you need to ask about the aura. The aura is the trigger, is what triggers the migraine. So again, in this case, a patient is coming with headache, the migraine headache. What are the criteria? Be careful, because the criteria are simply one-sided headache. The nature, throbbing sensation, moderate to severe throbbing sensation, gets worse when she moves on movement, and the headache is so severe that it prevents her from doing her daily activities. Other symptoms with the headache, she will say to you, I'm feeling sick, I feel sick, increased sensitivity to light and sound, Now, don't forget to ask about the aura, which is just before the headache. What was going on, or just before the headache, what were the problem, or what are the symptoms? So the aura, symptoms of the aura, it happens 1 in 3 people with migraine. They have aura, which is basically temporary warning signs, temporary warning symptoms. Like what? Like visual problems, seeing flashing lights, zigzag pattern. So that's one of the symptoms of the aura. Okay, numbness, tingling sensation, pins and needles, which start again on the face and lips and tongue. Again, that's one of the symptoms of the aura. Feeling dizzy or off balance. Again, difficulty speaking. Again, sometimes loss of consciousness, but it's unusual. Okay? So the aura symptoms develop 5 minutes, and sometimes last for up to 1 hour. Okay? So please, what are the positive symptoms for migraine? We know, and ask about the symptoms of the aura. And the aura, I said, 1 out of 3 people have these symptoms, and we spoke about it. Okay? Visual problem, tingling numbness in the face and lips, and feeling dizzy, off balance, difficulty in speaking, sometimes loss of consciousness. Okay? And in this kind of migraine headache, you will always have triggers. So always ask about the triggers or the factors. The factors will be emotional triggers. It could be emotional triggers like what? Stress, anxiety, sometimes excitement and depression. So that's number 1, emotional triggers. So migraine headache can be triggered by emotional things, extreme emotional things like stress and anxiety, depression, excitement. Number 2, that's emotional trigger. Physical triggers like tiredness, if the patient is tired, or poor posture, or jet lagged, if the patient is jet lagged, or poor quality of sleep. That's all physical triggers. So ask about the emotional triggers, or the patient will tell you. Ask about the physical triggers: tired, jet lagged, working in shifts, posture, poor posture. Okay? And then dietary triggers. Sometimes the patient can have any dietary triggers. For example, missed meals, yes. Dehydration, yes. Alcohol, yes. Caffeinated product like coffee, yes. Specific food like chocolate, like citrus fruit. All these are dietary triggers. Okay? Finally, environmental trigger. Like what environmental triggers? Like bright light, television, computer screen. Okay? Sometimes loud noise. These are all triggers that induces the migraine condition. Okay? Now, some types of sleeping tablets, medicine as triggers. So some medications can be triggers like what? Like sleeping tablets, for example. Okay? On examination, you must examine, check the observation, and again neurological. And now, migraine management. How to manage migraine. So now, we spoke about the migraine. I said to you it's just a headache. Explore it. Make sure you ask about the aura symptoms. As to recap, and make sure you ask about the triggers. And I said the triggers can be medicine, can be physical, can be environmental, can be that all should be included in the history. Now, how to manage migraine? Management of migraine. I'm gonna tell you something that you should be clear of. Okay? There is no cure for migraine. So there is no cure for migraine. However, management is just to help to ease the symptoms. So there is no cure for migraine. The management is simply easing the symptoms. Okay, so general advice. I'm gonna advise this patient about simply. What do you think? What do you think the general advice will be? Avoiding as well as identifying the trigger. So identifying and avoiding the trigger is the main thing. Which means if you notice that we said that there are some triggers: physical, psychological, emotional, environmental, medicine. So I need to know the trigger from history in order to address it in management. So in management, you must, once you identify the trigger, tell the patient to avoid it. So number 1 in management, I said to you, management is 2 parts: general advice as well as medications. So general advice and medications. So number 1, general advice. Number 2, medication. Number 3, prevention. General advice is not, what would I say in general advice? So identify and avoid the trigger, which you will get through the history. Number two, migraine diary. Again, write down when you have the headache, and write down the timing. The date, how long the attack lasted, and what symptoms that you experience. So That's migraine diary. So two things in the general advice. Number one, identifying as well as avoiding the trigger. Number two, migraine diary. And in the diary, date, time, triggers, symptoms, and the timing. How long this lasts. What is the second point after general advice? Medications. Medications as simple as painkiller. And when I say painkiller, painkillers such as what? It's over the counter. Paracetamol, aspirin, ibuprofen. Okay? As simple as that. As simple as that. Alright? So, any other management? Yes. Yes, when it comes to medication, I can give triptan. I can give triptan like sumatriptan. That's a specific painkiller for migraine. Triptan like sumatriptan. Okay? Number three, I can give other medication, anti-sickness medication. Anti-sickness medication because I said that the patient will be feeling sick. Anti-sickness medication because the patient will be feeling sick. That's it. So during the attack, I can ask the patient during the attack, sleeping or lying down in the dark room is the best thing to do during the attack. Alright? So sleeping or lying down in a dark room during the attack will help to relieve the problem. Okay? So basically, alright. Okay. So basically managing the migraine headache, or when you take history, make sure you explore the headache and you ask about the trigger. Why? Because I will manage the trigger. When you manage the headache, I said to you number one management is general advice. What is the general advice here? Identifying and avoiding the risk factor, migraine diary. Number two, medications. What are the medications here? As simple as paracetamol, ibuprofen, and it goes up to medication called sumatriptan, and you can even give anti-sickness because I said one of the symptoms is sickness. And you can basically tell the patient that when you have this, sleeping and lying down in the dark room will also help. And don't forget to talk about migraine headache. Don't forget to talk about acupuncture. Yes, it can play a role. The third type of headache, or the fourth type of headache, is GCA. Giant cell arthritis. So giant cell arthritis. You are an FY2 doctor in the medicine department. Monica, 57 years old, came to the hospital with headache. Take history, assess the patient condition, and discuss further management. Again, as simple as headache. How can I help you? Doctor, I have headache. Sympathy and empathy. I'm really sorry about that. Would you like me to give you painkiller? No. Tell me more about the headache. Socrates. Then what are the positive symptoms here? Number one, headache. Explore. Number two, pain and tenderness over the temple. Number three, pain on the jaw while eating or talking. Number four, visual problem like double vision, loss of vision. Okay. Number five, don't forget to ask about polymyalgia rheumatica, which is pain and stiffness on the shoulder. Always, if you have GCA, ask about polymyalgia rheumatica, which is pain in the shoulders. If you have polymyalgia rheumatica, ask about GCA, which is pain in the eye. So again, giant cell arthritis, one of the causes of headache. The patient will come with headache. Explore the headache. Tell me more. Ask about Socrates. Anything else? The patient will give you other symptoms. What are the symptoms here? The patient will come with headache, pain on the temple, pain on combing, pain on chewing, pain in the eye. Plus, or double vision. Plus, don't forget that the patient might present with polymyalgia rheumatica, which is pain on his shoulder or his hips. So pain in the shoulders. Okay? So on examination, again, you will check the vitals and fundoscope, and the nerves. This is not an examination station. Okay. Then you will basically give provisional diagnosis, and the provisional diagnosis is basically it is giant cell arthritis. It's basically autoimmune condition. The body defense mechanism attack its own cells, leading to this condition. So management. This is same day referral with eye specialist or ophthalmologist. So same day referral to eye specialist or ophthalmologist. Don't forget. What are the investigations I will do here? Investigations, ESR. ESR, ESR, and temporal artery biopsy, which will be done by the ophthalmologist, So with the referral, they will do biopsy. So don't forget, step one, same day referral to ophthalmologist. Initial investigation that you will do, ESR, blood including ESR. ESR will be high. Okay, then further investigation by the specialist, ultrasound scan of your temples, as well as biopsy. You will take sample, okay, temporal artery biopsy under local anesthesia. But will you wait for the biopsy result to give the steroids? No. So steroids will be given, medications. So this patient will be treated with steroid, prednisolone, okay. The treatment, should I wait for the biopsy? No. The treatment, the steroid will start right away before the biopsy result, okay. Now, how much steroid should we give? Initial high dose for 2 weeks, or you can even say for a few weeks, and then we will do tapering for the dose. So lower dose steroids will be used later. Okay? Any other medication? Yes. Because it's steroids, so I will talk to him or to her about that steroid side effect, and then I will be giving further medication. Steroid side effect like what? Like weight gain, there is risk of strokes, blood clot, high blood pressure as side effect. So I will be giving this patient low dose aspirin to reduce the risk of a stroke and the heart attack. I will give proton pump inhibitor like omeprazole to reduce the risk of gastric ulcer. I will give bisphosphonate to decrease the risk of osteoporosis, okay, and immunosuppressant sometimes. So I will recap the management. So giant cell arteritis management. How would you manage? Same day referral to ophthalmologist, number one. Number two, blood investigation that you will do, mainly ESR will be high. Number three, when you refer to ophthalmologist, they will do 2 things, ultrasound as well as biopsy. Do you wait for the biopsy result? No. We start the steroid right away. High or low dose? We start first with high dose, then for a few weeks, then they will decrease the dose of steroid, and then talk to the patient about side effect of steroid. So say that steroid can cause side effect like what? Like stomach ulcer, like heart attacks, strokes, many strokes, as well as osteoporosis, high blood pressure. However, we're gonna give you some medication like what? Aspirin, because he's gonna be on high dose for a while, and then low dose, sometimes for 2 years. So you need to give aspirin to decrease the heart attack and strokes. You will give bisphosphonate to decrease the osteoporosis, and you will give proton pump inhibitor like omeprazole to decrease the stomach ulcer. Don't forget to safety net. Safety net for what? Safety net for the condition GCA and for the complication of steroid, heart attack and stroke. So at any time you feel sudden pain in the eye, that's for the GCA. At any time you feel facial weakness, arm weakness, like the speech, chest pain, come right away. So I'm safety netting for 2 things. Safety netting for the steroids and safety netting for the GCA. So when you safety net for 2 things, GCA as well as steroid. Alright. Then the next case, subarachnoid hemorrhage. You are an FY2 doctor and A&E. Jack Albert, 45 years old, presented with headache. Talk to the patient, take history, do relevant examination, address the concern. Okay? In this case, they might say to you at 6-minute bell, talk to the examiner about management. Okay? If they don't, speak to the patient. So, how can I help you? All of them headache. I'm discussing headache. Doctor, I have headache. Are you comfortable talking to me? No, doctor, I have severe headache. Explore the headache. Tell me more. Socrates. And then anything else apart from the headache, he will give you other symptoms. So what are the positive findings here? The patient will give you headache. He will tell you it is the worst ever headache I've had in my life. Doctor, banging. It's like someone is banging. On the back of my head, on the occiput. Okay? So that is the description of the headache. It is the worst ever headache I've had in my life. Okay? Then what are the risk factors? The patient will have risk factors. Smoking, high blood pressure. The patient will have family history of sudden death. These are all risk factors. Kidney problem, kidney problem, kidney problem, okay, like polycystic kidney. So risk factors, again, high blood pressure, kidney problem, Endesa smoking, in Maftosa, family history of sudden death. These are the positive findings. Examination, normal, verbalize, vital signs, as well as neurological examination. Management, how to manage. Management, admit, number one. Admit, number one, admit. Investigations that will be done. Blood, all blood, including clotting profile. All blood including clotting profile. Don't forget that in the history, when the patient gives you headache, it will be, as I mentioned before early on, meningitis minus fever and rash. Meningitis minus fever and rash. So the patient will give you headache with neck stiffness. That's it. So severe headache, 10 out of 10 with neck stiffness. No fever, no rash. Shower from light, yes. No fever, no rash. So the main thing, it's like meningitis but without fever and rash. Anyway, coming back to the management. Investigations. What are the investigations that we will do to such patient? I said blood, number one, blood. Don't forget, okay? But what are the diagnostic investigations? CT scan that will show brain hemorrhage. Lumbar puncture. So CT scan and lumbar puncture. CT scan and lumbar puncture, okay? So lumbar puncture, they will take a sample, all right? So this patient will need ITU, intensive care unit, and he will need neurosurgeon, and he will need surgeon. Don't forget that further investigation will be done, like magnetic resonance angiography and computed tomography angiography. So don't forget that he will need dye scan. All right, special dye scan. Don't forget that this patient, in terms of management, he will need ITU. In terms of management, what medication does he need? This patient will need medication like nimodipine or nifedipine, calcium channel blocker. He will need calcium channel blocker 4 times a day for 3 weeks. Calcium channel blocker, nimodipine 4 times a day for 3 weeks. Okay, he will need severe, because it's severe pain, he will need painkiller like morphine. Okay, so that's in terms of management. And finally, surgery will be indicated in this case. So sometimes they need surgery and sometimes it leads to death. So surgery, they may need surgery. Okay, so now I will be recapping the management for subarachnoid hemorrhage. I said it's a headache, severe, 10 out of 10. Doctor, it's like someone is banging on my head. This patient will have what? Neck stiffness. This patient will have shower from light. So it's a meningitis symptoms without fever and rash. As I mentioned to you, don't forget about the risk factors. Risk factors will be the patient will have history of high blood pressure. The patient will have history of kidney problem, family history of sudden death, smoking. In management, don't forget that this patient will need admission, senior, investigation, blood, mainly clotting profile, and the patient will need CT scan, and the patient will need lumbar puncture. Further investigation will be needed after referral. Further investigation will be needed, which is CT angio, MR angio, dye test. Okay, what medication will be given? Nifedipine or nimodipine for 3 weeks, 60 mg 4 times a day for 3 weeks. It's a calcium channel blocker. This patient will need painkiller, and this patient will end up by being in the ITU. Further, sometimes it can lead to death, and sometimes it can lead to surgery. Sometimes surgery is indicated, sometimes it's not indicated. Okay. Meningitis. All right, meningitis. Again, you are an FY2 doctor, David Miller, 27 years old, presented with headache. Again, how can I help you? Doctor, I have headache. And when you open the cubicle, the patient will be covering his eyes. He will be shy away from light. He cannot look at the light. Shy away from light. Like this. He cannot look at the light. Okay? So how can I help you, doctor? Headache. Explore the headache. Tell me more about it. Then Socrates. When you explore Socrates, anything else apart from headache, he will give you other symptoms. So what are the positive symptoms here in this patient? The patient will have headache, Severe headache, 10 out of 10. The patient will have fever, high fever. The patient will have rash in his body. The patient will be shy away from light. The patient may be vomiting, confused, respiratory rate high, breathing quickly. Okay, neck stiffness. These are the symptoms. These are the presenting complaint of the meningitis, and it's more common in babies. So headache, severe, 10 out of 10. Shy away from light, neck stiffness, rash. Okay, he might have fits, breathing problem. All right. On examination, I'll examine our verbalized examination, vitals as well as neurological. Okay. Don't forget that the rash when you put the glass test, okay, it's non-blanching. Okay. Management of meningitis. First of all, when you give provisional diagnosis, what is meningitis? It's inflammation of the meninges, the covering of the brain. Okay. Meningitis management. Number 1, admit. 2, senior. 3, isolation and inform the infection control. 4 is investigations. What are the investigations? Again, the investigation, blood tests. I will do blood culture. So blood test, I will do blood culture. CT, and if CT is normal, I will do lumbar puncture. And CT is to check the brain and the swelling around the brain and the meninges, and lumbar puncture. So again, blood, mainly blood culture, everything, and blood culture. CT, lumbar puncture. Okay. The patient will need symptomatic treatment like morphine. Symptomatic treatment. The patient will need antibiotic through the veins. Antibiotic. The patient will need oxygen and fluid. If you think about it, it is, if you go back to day 1, which I said to you, that in the management, symptomatic management is your job. Oxygen, fluids, painkiller, antibiotic. That will be given here. Oxygen, breathing. IV fluids, painkiller, antibiotics. Investigations, blood, mainly blood culture, and we said CT scan, lumbar puncture. Okay. Now, steroids. Yes, steroids can be indicated here because it decreases or reduces the swelling around the brain. All right. Okay. So main thing is, don't forget to talk about the people in contact, people who were in contact, because they will need antibiotics as well. Okay. So, and this patient will need ICU. Okay. So sometimes we put them in the ICU. All right. So finally, and last station is hangover. You are an FY2 doctor in the GB clinic. Tom Stevenson, 18 years old, presented with headache. Talk to us as concerned. How can I help you, Tom? Doctor, I have headache. When you explore the headache, tell me more, Socrates. This headache will be only started in the morning when he woke up in the morning for the past 3-4 hours. It's bang like headache. It's there since it started. Okay. Then he will have sickness with this headache. He will have dehydration. He will tell you, doctor, I feel dehydrated. I feel sick. I feel dizzy. These are the symptoms. Okay. Basically, when you take the history, everything will be negative, apart from one thing, that he went to party last night. He drank plenty of alcohol, binge drinking, drank plenty of alcohol. So this is like a kind of hangover, kind of headache. So how can I help you, Dr. Headache? Tell me more, Socrates. He will tell you, doctor, 3 hours ago, I woke up in the morning with this headache, very bad headache. Anything else? Sometimes doctor is going to say, I feel sick. I feel like I want to vomit. Okay. I feel dehydrated, dizzy. Everything else is negative. But when you ask about alcohol, yes, he drank too much alcohol, binge drinking. Okay. Management of hangover. Management of hangover, as simple as no investigations needed. You don't need any investigations here. As simple as rehydration, plenty of fluids, some painkiller. But when you give him painkiller, don't give paracetamol. You can give ibuprofen. So some painkiller like ibuprofen. And main thing here is to advise him about the fact that he should not binge drinking. Because drinking too much will lead to hangover headache. Okay, so to avoid hangover, don't drink more than what your body can cope with. Okay, don't drink on an empty stomach. Don't drink and don't drink water or non-fizzy soft drinks in between the alcoholic drinks, so like mix it up. So basically we'll advise him about the fact that he should not binge drinking. Number 2, drink according to your ability of your body that your body can cope with. Number 3, don't drink on an empty stomach. Don't drink on an empty stomach. That's it. Okay, so this is the advice that you will give. Any painkiller? No painkiller. Okay, or you can give him ibuprofen, but the main thing is rehydration, having a rest, sleep, and that's it. And give him the advice about avoid drinking on an empty stomach, avoid drinking more than what his body can cope with, avoid binge drinking, which is drinking too much. Okay, thank you very much, guys. This is the end of the headache stations. Thank you very much.